Good morning. It's my pleasure to introduce Dr. Terry Fulmer, who will be presenting this year's Norma J. Shoemaker Honorary Lecture. Today's session has been developed in coordination with the American Geriatric Society. Next slide, please. Dr. Fulmer is president of the John A. Hartford Foundation in New York City, a foundation dedicated to improving the care of older adults. She serves as the chief strategist for the foundation, and her vision for better care of older adults is catalyzing the age-friendly health system social movement. She previously served as distinguished professor and dean of health sciences at Northeastern University and founding dean of the New York University College of Nursing. Dr. Fulmer is nationally and internationally recognized as a leading expert in geriatrics and is also known for conceptualization and development of the National Niche Program and research on the topic of elder abuse and neglect. She's an elected member of the National Academy of Medicine, is the first nurse to have served on the board of the American Geriatric Society, and is also the first nurse to have served as president of the Gerontological Society of America, which awarded her the 2019 Donald P. Kent Award for exemplifying the highest standards for professional leadership in the field of aging. Please join me in welcoming Dr. Terry Fulmer as she presents Why the 4M's Approach to Critical Care Improves Quality, Lessons from the Age-Friendly Health Systems Movement.
Good morning, everybody. I am so happy to be here and talk with you today about our age-friendly health system work, and particularly honored to be the deliverer of the Norma Shoemaker Honorary Lecture. As I read it, Norma Shoemaker is responsible for founding this organization along with her husband. And as I read about her, I learned that he had the vision and began the society, and she did all the backroom work, getting people to the meetings, organizing. Some of you may have had the privilege of knowing her, but I feel privileged to be in this very honored position today. So today I'm going to talk to you about our age-friendly health system movement and talk with you about why your organization, you as clinicians, you as care providers, are the most important group to move this work forward. So the John A. Hartford Foundation is a private philanthropy, bipartisan private philanthropy based in New York City, and we were established by A&P grocery stores. How many of you remember A&P grocery stores? Yeah, so there used to be, listen to this, at one point there were 15,000 A&P grocery stores here and around the world. By contrast, there are 7,000 Walmarts in our country, so think about that, right? You think there's a Walmart everywhere. But John and George Hartford, when they began their foundation in 1929, started it to say, do the greatest good for the greatest number. And by the 80s, the early 80s, the trustees decided to focus on aging and geriatrics. And that makes sense because it was 1975 when the National Institute on Aging was formed. And so before then, there really wasn't an NIH group to really focus on the science and so the foundation was funding some science. And then with that, really moved to generating the workforce for geriatrics and programs of excellence and models of care. And from that, our work today. So the mission of our foundation is we are dedicated to improving the care of older adults. We are very pleased that our priority areas, if you think about the umbrella of age-friendly care, then you know that we're focused on creating age-friendly health systems. 10 years ago when I began my job, I said, I'm going to work on creating age-friendly health systems because there's no such thing. And now there is. and I have learned so much from all of you who are working on this with me. Supporting family caregivers. There are about 45 million family caregivers out there saying, what do I do now? Many of them go home with tubes, strips, and drains and are terrified that they're going to hurt the person they're caring for. And so supporting family caregivers and really thinking about the ways that we can connect them with age-friendly. And then improving serious illness, your life's work, and end-of-life care. Not to be conflated, they're very different, but improving serious illness and end-of-life care. And we were I wasn't there so I can brag, we were the foundation that began CAPCE, that Center for Advancing Palliative Care. We believe that our context is obvious, and that is we all need an age-friendly society. Longevity is the greatest success story of the 20th century. Very clear, if you were born in 1900, you would probably live to be about 47 years old, and we have doubled that. So that's amazing success. And the second thing I say, and I don't have it on the slide, is that we love saving people, but we don't always love taking care of people. And so that's my life's work. I began my career at the Beth Israel Hospital in Boston, now BI DMC. Anybody here from BI? You never know. So I began my work, and what I saw as a practicing nurse was just that. You know, if somebody had a cardiac arrest, we would get their heart going again, but then they were no longer an interesting case. Context, 1975, House of God, Gomers, get out of my emergency room, grand old men of the emergency room, you know, vitamin H, Haldol. That was so I found my love. I knew what I was going to do right then and there, and that was focus on geriatrics. Whenever I said I was going to focus on geriatrics, people said, oh, so you work in a nursing home? No, I do not. Like nursing homes, wouldn't mind working in a nursing home, but I work in acute care. So longevity. As we age, we make vital contributions, and we really can power up communities with support. Linda Freed, who's the Dean of Public Health at Columbia University and also a geriatrician, talks about the longevity dividend. So that is those extra years and what one can do with them. And then a just society requires us to make all sectors age-friendly. We also fund age-friendly public health systems. We made that connection as fast as we could because our public health system in America, led by CDC, has heretofore not really focused on older people, but they are now. And so they're working with our AAAs, our area agencies on aging, and we have to knit this together so that we have age-friendly care everywhere people are. We work with the workplaces, home-based communities, cities, communities. And where did we get the term age-friendly? It sounds like a cheap moniker, and it isn't. The World Health Organization coined the term in 2006. Alex Kalachi, a physician from Brazil, started age-friendly cities. He moved that to age-friendly communities. And in this country, if you're an age-friendly community, you have to be designated by AARP. And they have a big foundation, too, that has done a lot for aging, obviously. And then we started our work with age-friendly health systems in 2016, and I'm going to talk about that. So why, again, demography, older adults, rapidly growing, more diverse, and complexity. We know that older people are more likely to have several conditions, and they're more likely to have dementia. As you get older, you're more likely to have dementia. The data are clear. Disability isolation, very serious, and our Surgeon General in the last administration did a beautiful job reminding us about social isolation as a serious health issue. And social drivers of health are sometimes not in the right domain for older people. So really helping with complexity and disproportionate harm, higher rates of healthcare related harm. We also work with the Society for Diagnostic Excellence and diagnostic work on improving diagnostic care for older adults. Discoordination. I don't have to explain to you that we have multiple clinicians working with us every single day, and that it is not unusual to have teams unaware of what the other team is doing. So we really work on coordinated care and poor preparation for disasters. Think about what we had to do in Los Angeles. Anybody here from Los Angeles? There you are. Thank you for everything you did to help older people during those horrible fires, evacuating nursing homes. Gives me the chills to think about what you've all had to go through. Floods, Hurricane Katrina, and what have we learned? So we really have to think about how we prepare for disasters for everybody, but particularly for older people who are vulnerable. So older adults are demanding age-friendly care, and what we did recently was we funded Age Wave. This is a group, again, in Los Angeles, San Francisco, age-friendly, Age Wave. And we worked with the Harris poll with a highly representative, a really awesome sample of 2,500 older adults, and only 11% of the respondents give an overall grade of A to our healthcare system, 11%, so 1 in 10. And we need to change that, and we can change that. But here are the most recent data. This was about 6 months ago. 82% say that our health system is not prepared for the growing and changing needs of an aging population in 2025, so we need to address this. And we want to. It's just, as my friend Jim Hall says in Boston, all of us in healthcare suffer from Project Titus, right? So, and I'm a nurse, very proud to be a nurse, and I know that if I wait long enough, you will go away. You and your project will go away, and we'll be on to the next thing. And of course, I'm teasing, but to say that you have to be very, very dedicated and gritty, and you have to stick with it. So that's our age-friendly health system movement. Let me talk to you a little bit about what I'm talking about. Our aim in our age-friendly health systems work is to build a movement so all care with older adults is equitable and age-friendly, guided by an essential set of evidence, which I'll tell you how we got to them, that are based on our 4 M's, that cause no harm, is consistent with what matters to the older adults and their family. And we know that about 40 to 50% of critical care admissions may be people 65 and older. So this is very vital to your practice. And what are the 4 M's? So we always start with what matters, goals and directives that older people have for their care. And I know that you asked that too. I also know that the daughter from New York comes flying in and has a different set of ideas than the older person, and the son who is a physician in Rochester, New York, also has a different set of ideas. Your job is hard, but your job is doable, and it's just keeping with that, what matters most to you. When I'm in practice at Mount Sinai in New York City, what I learn is that they say, well, when I say what matters, they'll say, get me out of here. That's what matters to me, get me out of here. So you have to coach it a little bit and, put it in context. You're in the middle of getting treatment for your pulmonary edema, and we're worried about the way that you're breathing. And so, let's think about your goals beforehand. And ideally, every one of you in this room has an advance directive. It's so interesting. In my own office at the John A. Hartford Foundation, I'll say, everybody got an advance directive? And they go, not yet, but I'm gonna. When? When? If not now, when? Okay, so do that, please. And Don Berwick, the famous Don Berwick, people know who Don is? So he founded IHI, was head of CMS. He says, hope is not a plan. Some is not a number, and soon is not a time. Isn't that great? So think about Don when you think about getting your family's advance directives going. So what matters? Medication. We all know that there are medications that are a bad idea for older adults. Many of you take a look at the Beers criteria. I knew Mark Beers. Mark Beers and I worked together. I was very proud to work with Mark, who died far too young, 51 years old, of juvenile onset diabetes and the ravages of that disease, even in the context of a very, very knowledgeable physician. But Mark, he started his whole Beers criteria because he saw so much harm. And of course, then the list became so long that all of a us ignored it. And now if you look again, there are 7 categories that you really should look at. So medications, not just over-medicating, but under-medicating. And I heard from colleagues yesterday in your session about making sure that you're paying attention to the right doses at the right time. Mentation, mood, memory, mind, your mentation. In your organization, in your field, you think a lot about delirium, but remember there's delirium superimposed on dementia, there's depression, there are underlying psychopathologies that happen. You might have somebody who's bipolar in the midst of all their care. So really thinking about cognitive status. I laugh when I say oriented times 3. What does that really mean? You know, really, can we do a UB2, please? It's the, you know, your ultra brief screen, 2 questions, and that would help. I have dear friends I work with at Mount Sinai, and one of the physicians I worked with, I said to him, so on our floor, how do we assess cognitive status? And he said, you know, I never really thought about that. I'll tell you. So he came back and he said, well, Terry, we all do it, but we do it our own way. I said, then you don't do it. Then you don't do it. If you can't look in a record and have a dependent variable with changed state, then you don't have the ability to look at cognitive impairment. So please do. At IHI, where we do so much of our work, we don't think about what instrument you choose is up to you. Whatever you love, please use it, but use it regularly and reliably. Mobility. I know you have a mobility track here in your society. I know you're doing really great things with that. And I was talking with someone earlier, and there are groups of you from Yale here today. When I was at Yale, I was on a falls committee. When I was at Beth Israel, I was on a falls committee. When I was at Columbia, I was on a falls committee. There's a lot of falls committees. And thank goodness we finally shifted it to mobility so that people go, you know, time to stop talking about falls and talk about mobility, safe mobility, regular mobility, to avoid deconditioning. So these 4 things are a set. It's not okay to do one. You have to reliably do 4 things as a set. I know you can do this. EPIC has a module now on this. Cerner's getting a module on this. If I can tell you the best health systems in the country to do this work. But think of it as a set. Julia Adler-Milstein is leading a research center at UCSF on age-friendly care and looking at outcomes from the set. And so for those of you interested, please, we said to Julia, let us know how much funding you need to do your work. And the last call she had, there were 400 people on it. So that's a good sign. We've worked with CMS for probably 7 years now. And we now have an age-friendly hospital measure that went into being January 1st. So this is the coolest for us at the foundation, where you work and work and work and work with CMS, and we have an age-friendly hospital measure built on 4M age-friendly care. There's a code there if you'd like to read more about it, and I'll talk about it briefly. But it's a hospital inpatient quality reporting program, pay for reporting. Participant hospitals are required to report on eliciting patients' healthcare goals, what matters, managing medication, documenting it carefully, implementing frailty screening, there's your mentation and your mobility, assessing social vulnerability, and designating age-friendly care leaders in your system. And by the way, the last one is the most important. When you have a person who says, I'll take that on, and you've got a champion, it works. So the data will be public on Medicare Care Compare. We expect that data to go up by the end of the year, by December. And age-friendly health systems and related initiatives help hospital measures. We have had an enormous uptick in our groups because of this measure. And we are happy to help anybody who is thinking about this work. It is a pay for performance, and it is required. So these are the domains, and I have this here only because you can download the slides and read it when you're home, but the domains are eliciting goals, responsible medication management, frailty screening and intervention, social vulnerability, and age-friendly care leadership, with goals and ways in which you can get that work done and what the attestations are. So our movement, and if you go to ihi.org/age-friendly, is one that is supported by us with the Institute. I don't know what I would do without the Institute for Healthcare Improvement and the American Hospital Association and the Catholic Health Association of the United States. By the way, 1 in 5 clinical care visits in this country is to a Catholic Health Association member. Isn't that interesting? So we have a learning action collaborative that in the fall is IHI, in the spring it's AHA, and they are identical in their content in order to help groups from different health systems come in, get trained, and move age-friendly throughout their system. So again, the whole idea is to have your set of care, your what matters, knowing and aligning care with each older adult's specific health outcome goals, medications, if medications are necessary, using age-friendly medications that do not interfere with what matters to the older adult, their mobility, mentation across settings of care, mentation, preventing, identifying, treating, and managing delirium, depression, dementia, and making sure that people know that that older person, I'm assuming you already have their hearing aids in and their glasses on at the time you're doing your screens, and making sure that you are helping older adults move safely every day. And I've seen the people in the ICUs get individuals standing with their ventilators, and boy, that would not have happened. Anybody, if I said Bullfinch, does anybody know what that unit is in Boston? The Bullfinch, there you go. So critical care, I worked in the intensive care unit in Bullfinch building at Mass General a long time ago, and there was no way somebody was getting out of bed with a ventilator. And so look, we say to ourselves, what are we doing today that we're gonna laugh at 20 years from now? So Bullfinch, there you go. It's now all office buildings. It's quite lovely, actually. So how did we get to 4Ms? It's like, what are you talking about, Terry? So we looked, our foundation had previously funded the development of models of care. And so we did a study of about 17 care models with level 1 or 2A evidence and looked at the impact, at some of the impact of those models. And what we were able to do by pulling them apart is identify 90 care features in our pre-work. And then we removed redundant concepts and came up with 13 discrete features found by our IHI team. Now, if I said to you, I'd really like you to just remember 13 things, do you mind? What are you going to say? Of course you're going to say, that's not going to happen. But with an expert meeting, we had expert in geriatrics and expert clinicians and expert people in health systems come together, and they all agreed that they could live with the vital few, the 4Ms. We were a little testy with each other because everybody has their own personal favorite, and you had to leave your ego at the door and say, okay, I'm going to go with this. I go out and I talk at a lot of places, and people say, I have a 5th M. I say, I think that's great. You can have 20 M's if you want, as long as you do the first 4. And so Ascension, anybody here from Ascension? Right off the bat, they said to me, we have a 5th M and it's malnutrition. I said, I love that. Please do that. Others have told me we have maltreatment of older adults. Please do the first 4. If you do it reliably, you've got it documented, add your M's as you see fit. But we came up with 4, and that was a big day. We called it our FOMO meeting. It was August of 2016. I remember Bruce left. Some of you might know Bruce from Hopkins. He came in off the beach. That's when you know you've got a meeting that somebody doesn't want to miss. We tease him to this day. So why the 4Ms again? They represent core health issues. They build on evidence, and they simplify and reduce implementation and measurement burden. We say we'd like to reduce your cognitive load. You've got all these scattered things in your life that you're all thinking about as you practice, and you're taking care of frail older adults who are very, very sick. And I have worked in ICUs, and I understand. And I know that if someone said to me, but while you're at it, can you do these 4 things? I can do those 4 things because I'm doing them anyway. That's the other thing. You go to most practice sites and they say, well, we do that. I said, really? Can you prove it? That's right. Right there is where the conversation gets a little off because they can, but they have to think about it and be reliable. And the components are synergistic and reinforce one another. If you have the wrong med, people are going to fall. People are going to get confused. People are not going to be able to tell you their goals of care. So the guide to using 4Ms in hospital care, we have so much literature available for free on the IHI and AHA website and our website. So there's a guide to using 4Ms in hospitals that helps you assess and know the 4Ms and takes you through exactly how you might do that, what measures you might consider, and what measures you might already be using. So there are guides. The reason I'm showing you this is to say you don't have to invent anything. The guides are there. Our age-friendly health system measures. What we tried to do is we began to say, what do you have to do anyway? And if we start at the right-hand column with your outcome measures, you have to know these things anyway, your 30-day readmissions, your HCAHPS, your length of stay, your ED utilization, delirium episodes. So then, what would you start with? Well, making sure that you are counting older adults and understanding your numerator and denominator and accessing the 4Ms in healthcare, finding out how many people are actually getting reliable 4M care, and then thinking about your process measures, your documentation, the medications that you're using and the way you're following those, and then your screens that you choose for your mentation and mobility. So it's a growing movement. We're in 4,800 healthcare settings right now, and I can't wait to hit 5,000. And, you get to 4,800, it's like, come on, you guys, sign up so that we can get to our 5,000, which it always feels so good when you click past another 1,000 sites. And very excited that we have about 4,800 hospitals, practices, convenient care clinics. 100% of CVS Minute clinics are age-friendly, certified by IHI, and they have the best data set. They have like over 9 million visits so far in their cases. So if you wanted to do research, they've got a great data set. And then we have 2,300 plus who are committed to care excellence. We're currently working with Leapfrog, Press Ganey, Joint Commission in order to get each of those organizations to additionally create mechanisms to encourage people to do this work. So interesting to me and to all of us, we turned around and all of a sudden IHI Open Schools had 53 countries who were taking the module on age-friendly. And countries who sent in their materials to be recognized by IHI as participants, which you can read on the screen. And it's been so heartwarming to see this. And I said, I wonder what's going on there. Well, we're talking about human function, aren't we? We're not talking about an ICD-9 code. We're talking about, can you walk? Do you have clear thinking? Are your meds okay? Do you feel good about the goals and preferences that you're working with? And so, Ireland sends us a letter saying, you should congratulate us, we're 100% age-friendly, and that is wonderful. And so having visited a number of these locations and seeing their work, it's just the way in which we come together as humanity, because these are very basics in the care that we want to receive. This is a small representation of our partners that work with us every day to advance age-friendly health systems. And AGS, I want to thank AGS again. Nancy Lundenberg, the CEO of AGS, recommended me for this talk, and I'm so grateful because I just really want to work with all of you, and thanks to AGS for their partnership with your organization. So as you look across, you'll see that there are foundations. The VA, 100% age-friendly. Some of you might know the name Carolyn Clancy. She's very senior in the VA. Anybody here work in the VA? There you go. So Carolyn Clancy. And Kim Church is their designated point person, and she is like a dog with a bone. Every single VA has age-friendly health systems in their day-to-day practice. So we look to put your moniker. You're now going on this slide. By virtue of the fact that I was here, I'm going to consider you a growing partner. So what are the drivers that I just mentioned a few, but let's talk about drivers. And that is, you have to have payment, regulatory measures. We all say, pay for, you do what you get paid for. And I know that you do what's right for your patient, first and foremost. But this inpatient quality reporting is helping us a great deal already with the interest and people committing to take on the work. And we are also working with a group of Medicare Advantage plans because we want to know what an age-friendly MA plan looks like. And so we're very pleased with the progress there. Our education, we mentioned, and there's something called the Geriatric Workforce Enhancement Programs in this country, the GWEPs, and our foundation funds the GWEP Coordinating Center, and they are doing really, you can't become a GWEP unless you demonstrate age-friendly care. So that is a great driver of change. Certification and accreditation, I mentioned, CHAP and NCQA, Joint Commission. We're working with the electronic health records and aligning the evidence-based models so that we can streamline adoption and recognition. So for example, if you are an organization that already has a niche program, anybody have a niche program? There you go. My friends in the back from Los Angeles, thank you. So niche is Nurses Improving Care for Health Systems Elderly. I started that when I was at the Beth Israel in Boston, and we have a textbook on it. But the idea is that if you already have a HELP program, Hospital Elder Life Program, that one was started by Sharon Inouye at Yale when she was there. So if you already have a program, or your surgical verification program, the American College of Surgeons has been the key driver to that CMS measure. If you've already got one, that's your leg up, and you're already doing age-friendly care. We just have to help you map on it. And then thinking about demands for older adults and family caregivers. And so we're working with the Rush Caregiving Program. And we also do shameless, what I call infomercials, where we pay NBC News to talk about age-friendly in commercials. And we're proud of it, and we love to see people call us afterwards. We see an enormous uptick whenever we do those. We also started a page on WebMD because we believe the public looks at WebMD. I bet a lot of your family does. And so we now have an age-friendly page with WebMD, and we're grateful to John White, who's the Chief Medical Officer at WebMD. We try to think of every vector of change that we can. We want the public to demand age-friendly, and we want all of us to be able to deliver it. So results and impact, here's some examples. Cedars-Sinai Medical Center used their 4Ms geriatric fracture program to embed the 4Ms, and they were able to demonstrate that they had lower length of stay and lower direct costs by virtue of the fact that they began their 4Ms age-friendly journey. And again, all these slides are available so you can read the papers. The VA in Boston, at their skilled nursing facility, early clinical and quality impact of their age-friendly health systems, and Andrea Schwartz is really a champion in that town, showed that you have short stay, your rehab had a 48% ED utilization decrease, 30% rehospitalization decrease, 19% increase, discharge to the community instead of living in a nursing home. Long-term care, 73% ED utilization decrease. That's huge, 64% decrease in hospitalizations. These are compelling numbers. From Providence Health, provider champions were trained in primary care clinics, and they found a 2 to 7% decrease in hospitalizations, twice as likely to screen for fall and cognitive impairment, and 4 times more likely to receive fall risk interventions. And we have provider champions tell us that this is really important to them and that they feel confident. When I began my geriatric work, people teased me. As I was practicing, people would say, oh, here comes one of Fulmer's kind of patients. And, nobody's immune to being heckled in practice. And I just had to really be sturdy. Be sturdy. When people say, oh my God, you're worried about that, we got all these other things to worry about. Be sturdy. Stay the course. So here at St. James Parish, 25 beds, people. Anybody work in a 25-bed hospital here? I didn't think so. So St. James Parish, using limited resources, a critical access hospital, we have many critical access hospitals, found a 62% decrease in readmissions over that period of time, $93,000 cost savings. That's a lot of money if you have 25 beds. And their falls and injury continue to decrease. They have a champion. So a wake-up call. Most older adults are not getting the 4M set. They are all, for those who say, I get all of those, I remember that, or my family remembers that, it's about 19%. So I'm asking you to be intentional. And we know we can get better outcomes because if you receive the age-friendly set, you're going to be more likely to give your healthcare provider a grade A. You're going to give your quality a higher grade. You're going to engage in healthier habits, exercise, diet, socialization, and purpose, and report overall health as excellent or very good more often than if you don't get your forum care. So resources and programs, and I'm watching the clock with all of you to make sure I don't go over and we have time. Here is one of the multiple guides available to you without cost. I don't say it's free because our foundation has now put about $24 million into this work. So, but this is a guide to using forums care in adult hospitals and ambulatory care practices. Work with me, particularly this front row, to get a guide for critical care, and we'll knock that out. You will. I love that. So resource guides, key actions for implementation and how to measure, and critical care version coming with all of you influencing it. How to have conversations. Now, we also fund Mary Tinetti's work at Yale, where she has patient care priorities, patient priorities care, PPC. And the idea of how you begin that conversation, and I think critical care people are probably best at it because it's so urgent in the moment, but thinking about how to have that conversation, and if you knew people preoperatively and you could get that conversation documented before. So it's very often current care planning rather than advanced care planning that goes on, but how to have it if you're stuck and if you have new clinicians who need help. This book we self-published. I'm very proud of that. I'm an academic. I worked 37 years in higher education, and of course you would never self-publish because it wouldn't count toward tenure. But we self-published this one because I want the copyright because I want to give it away for as cheaply as possible. I think this book costs $15 used on Amazon and maybe $19 new. But what we did was we took every single one of the guides and put it front to back into a book because some of us like that. It's just easier to do that. And so I think that is something that we found useful. And we did a second edition. We'll probably do a third soon. So providing age-friendly care to older adults. We have an open school course, and this is for all of the learners in your group who would like to do that. And the course outlines age-friendly care, Forum's age-friendly health systems network, and how to assess, and learners from 45 countries have taken that course. The role of the EHR we know is essential, and so thinking about the guides available for incorporating into EPIC and Cerner, this is an adaptation guide, and ongoing research and development is currently happening. If you are having trouble, please let us know, and we will be in touch with the people we work with. The value proposition is always important in our practice, where we have to talk about value, which is your outcomes over cost. And so these documents that are available to you talk about the business case. There is an inpatient return on investment calculator, an outpatient return on investment calculator, and creating value is an important material here. So UCSF has a research network. I mentioned them. Really proud of that work. I think you remember that, aren't you? There's our organ health sciences expert right here with us, Katie Drago. Thank you for being here. Your work is amazing, and this is a person to ask when you have questions. Thank you. So UCSF, Age-Friendly Health Systems Research Network, tell them what you need, and they will work with you. Here is our evaluation metrics resource. So this is one-stop collection of forum metrics collected by UCSF and the Research Council that they've developed, because you're busy people. So if you want to explore that library, there it is. And again, these slides are available along with the scan. Other age-friendly clinical programs include our Geri ED program. Thank you to the Geriatric Emergency Department Collaborative. They have just worked wonders with age-friendly care. Kevin Bice comes to mind immediately in his work at UNC. along with his team, training the Jerry ED Collaborative to be age-friendly, working together. They have accreditation, and our geriatric surgery verification meets the standards and being verified. Again, I know that it was the American College of Surgeons that made that CMS measure come true, and Cliff Coe at the American College of Surgeons was leading the charge, so thank you to Cliff publicly. So please join us. If you want to join us and quit later, you can do that, but try it, please. And just, there are many on-ramps. So there are action communities for teams to learn. The next one starts in March. You can do it yourself. UCSF decided to do it themselves. They didn't want to join an action community. That's okay with me. They did it themselves, and they are awesome. So you take the material, you test it, you work forward, you send your material in. You choose not to be in an action collaborative, but you want to do the work. And so I love that. We want to make it easy for people to be successful. And here are some websites that help you join us in the age-friendly health systems movement. Kate Armate was president of IHI, the CEO of IHI for the last 8 years, and he has since transitioned to another job, and I miss him dearly. But when we started our work together, he said to me, you know, Terry, you have to be comfortable losing control of the process. And that's important. Because what I find is when I look at the literature, I have no idea that people are doing this work or that people have advanced the work and improved it, and that's a measure of success. So be comfortable losing control of the process. Not too soon, but, and I'll tell you where I dug in my heels. I created the logo, and I made sure the logo matched the age-friendly public health system logo because, and I said to the group, get the banners ready, because otherwise everybody's gonna publish something that they like, and we won't have a brand, and people won't know it's an age-friendly system. So think about that when you have your programs as well. So in summary, with our 4 minutes left, I want to thank you. It's a privilege to talk to you. I'm grateful to you for the care that you give every day, for the lives that you save, for the people you help die peacefully. It's hard, hard work. And I think it's a testament to all of you that you're here today. I know you want to give the best care possible, and I hope we can help you in any way that you might encourage us. Thank you very much.